We are delighted to welcome you to SafeBirth4All Conference. The theme today is Hope, Healing and a World Without Obstetric Fistula. So we welcome you today. Thank you to everyone who braved traffic and is in the room with us. And thank you so much to everyone who is online with us at this time as well. We're very grateful to have you all here. So thank you so much for that. I'm just going to go over the agenda with you for this morning so you know what's happening. This is us doing the welcome, so we're on our way. We have a short video that we're going to share with you. And then we are so grateful that Sister Sylvia is here with us in the room, and she is going to do a little question and answer talk. As you can hear, people are doing some introductions in the room as people are being welcomed. So then we will have an introduction to the pillars, the 4 pillars that will be explained to you by Dr. Shane Duffy and by Jacqueline, who are both here in the room with us. We'll have a short break at 11:25, and then we will go into group discussions, which will be happening both in the room and also happening online. So we really do hope that you will stay with us for those group discussions. At 12:05, there will be a short break, and then at 12:15, we will come back for feedback sessions in the room and online. You'll be able to hear feedback from the discussion, and then we will have reflections, key takeaways, and next steps. So we are scheduled to finish at 1 o'clock. And for those of you in the room, there's lunch. And for those of you at home, I hope you plan on something lovely for yourself. And we are very grateful to have you here. Many of you were with us last year, but we're very delighted to share that we have more than doubled our attendance this year, and that is very exciting. As many of you know, SafeBirth4All is a coalition that began in Ireland as a coalition of people who care deeply and want to see prevention and treatment, advocacy, and rehabilitation for people with obstetric fistula in the world. So what we thought would be best, and I do believe this is the very best thing, is to share with you a video that was done for us by one of our sisters, Sister Otterborn, who did this video specifically to bring the voices of the women and girls impacted by obstetric fistula to us directly. So we're going to take a moment now and watch the short video.
At the Pope John Paul II Vesical Vaginal Fistula Hospital in Itam, healing is not just a medical procedure. It is the quiet restoration of dignity. Here, women arrive carrying more than physical wounds. They come with stories of prolonged labor, limited access to care, and years, if not decades, of isolation. These are not isolated voices. They echo across communities where safe birth is still not guaranteed.
What made me here? I was pregnant. As I went to health center to deliver the baby, I couldn't. The health center transferred me to the TBA. I now try it again. I couldn't. Now send me to General Hospital around. And I do me CS there. The baby dead. Then I now come and know that I have leakage. RVF and VVF. Yes. After the first sudden here, he ran away.
I gave birth to a baby, then I had a tear in my vagina. So I asked people to and fro, even went to the hospital. I have no solution. I take medication, no solution. So my neighbor took me to this hospital, VVF hospital. Okay, during child delivery, it was hard for the baby to come out, so the person that attended to me feared it. The TBA feared for the baby to come out. Now it starts leaking pop and gas, or even though I want to defecate, this will be coming out from the body. So during the process, my husband ran away from me and left the house for my parents. Only my grandma and my grandpa helped me before they came in out to breastfeed. And now I'm waiting for my son. I did not pay for the surgery that I'm coming for. It's 100% free, even with feeding.
Ngeba ke esa abioman kerang. Ngeba manti meri bene anyong fo. Mindi ba ku ngai meronga sangayira pa mindi ba ke esa abioman. So anti meri bene ka ufo ba minge bang kwene. Ngeba mkwene. So awi mai kwede ko ufo ba fen ninyo. Edisio katete ikmero tungo anlik. In the use spaces since in make math. So a getting do operation go forgive or in CS that's your DNA Benet DNA mapa. So a CRA Benet book.
These are not isolated voices. They echo across communities where safe birth is still not guaranteed.
Here, we have quite a lot of deliveries happening in spiritual homes, if I may use that word. I'm distilling that from the activities of traditional birth attendants. Traditional birth attendants are one subset of enablers and feeders of this problem.
And I don't know, it is sad that presently people are still, no matter what we are doing now, there are still people out there that they still have BVF, they still have RVF. We do a lot of creation of awareness with the help of our outreach team. We go out, they go out 3 times a week. And then once a month, they go out to the church directly. The 3 times in a week, we go to markets, to create awareness, to talk about VVF, to talk about RVF. We go to schools, they say catch them young. When we go, we try and talk with the children about VVF, about RVF, and we encourage them no matter what, with time. Even in their neighborhood, if they see a woman pregnant, they can help out, even as young as they are. And then when their own time comes, they should try, because together we want to put an end to VVF, we want to put an end to RVF, because it's not something that one would wish any woman.
This is where fistula begins. And yet, here in Itam, something powerful is happening. Surgery restores continence. But more than that, it restores identity.
All the surgeries that we carry out, whether it's during camp or whether it's the routine surgeries, the patients don't pay. They don't pay.
So now I'm dry, I'm okay, I'm very happy. I'm very thank God for what you have done for me. I'm very happy, very, very happy. I can go out now, even to the church, I can go, even in the market, I can go. Like in this my working place, I can sit and feel comfortable without thinking anything, because I'm dry. Everyone is good. Now I'm okay. Then I decided to stay here and learn to walk. I'm learning so many things. I can make hair, I can do makeup, I can bake, I can do eyeshadow, I can make liquid soap. We learned a lot of things here.
But repair is not enough. For every woman treated, many more remain unseen, waiting, hoping, forgotten.
Okay, thank you very much. As I said, that was an opportunity for us to hear specifically from women who have had the experience with this, and we felt that that was very important to present them as part of our opening today. So at this time, we're going to move on with our agenda, and we are going to have a chat with Sister Sylvia, who was born in Nigeria and joined MMM in 1985. She's a nurse midwife and development worker trained in Nigeria and in Ireland. Sister Sylvia has had a number of roles over the past 40 years, working within 7 different MMM ministries, projects in various countries. She has been in leadership roles in West Africa since 2022. Prior to that, she was matron of a VVF obstetric fistula hospital in Etam, Nigeria, where she worked from 2013. Touched by the suffering of fistula survivors, she oversaw the strengthening of quarterly VVF obstetric fistula pooled surgical camps, increased collaboration with local organizations, and advocating for women with or at risk of obstetric fistula nationally. In 2018, after herself surviving a kidnapping attempt, she committed herself to empowering young people on their rights, responsibilities, seeking justice for survivors. I can tell you firsthand that Sister Ursula Sharp, our MMM congregational leader, encouraged me to talk with Sister Sylvia, and I did. And she said, will you speak to some other people about SafeBirth4All? And in 2 weeks' time, there were 70 people on a Zoom call to learn about. I was so impressed, and I remain impressed. So I know you will be too. So I'm going to invite Sister Sylvia to the front of the room, and we're going to have a little chat. Okay, thank you. You can already see her enthusiasm and passion for this. Just radiating. So can you tell me what sparked your passion for obstetric fistula and VVF?
Thank you. Every human is born with dignity, with respect and worth. And if there is anything that will slip this gift, free gift, from a woman, from anybody, it's injustice, and it shouldn't allow it to happen. And for me, such should be fought against locally and globally. Again, we all know that we all have the right to good health. And when this good health is stolen, or anything that will steal this away from us, it's unjust, it's unfair anyway. And this is exactly what VVF, obstetric fistula, does. It steals the rights of a woman. Not just a woman. VVF is not just affecting one woman. It's not just, it's not a disgrace to the woman, and it's not just affecting the woman. But VVF, I see it as an assault to womanhood itself. And for me, such should not be allowed to exist in a society. And any society that allows such dehumanization to stay is a disgrace, it's a shame, because it affects the whole human being. Why am I saying this? My first encounter with a woman with VVF, it made me to cry and ask myself, what am I contributing in the society to make our society a better one? I saw a woman, I was driving up, that was in 2015 or so. I was driving out of the compound. No, 2013, I went to Etam. I met a woman at the gate, and she was carrying loads. And so seeing a woman coming from, seeing her, you know she's coming from a village anyway. So I parked the car to go and welcome her. Although the gate men were there, they have opened the gate to her. So approaching the woman, she was moving backwards. Going further, she was moving backwards. So I was wondering, what is wrong with her? So I said, welcome, my sister. She said, don't come near. I'm smelling. So with that, I felt cold, but I went ahead and grabbed her. She started crying, weeping. She said, I'm smelling. Leave me, leave me. So I took the load from her head onto my own. I put the load on my head and took her hand as we were going. So one of the gate men saw me, ran, took the load from my head and took the one on there. So I said to the gate man, go ahead, keep the load in the wards. We are coming. So I started talking with the woman, trying to reach her even. Holding her hand, this woman was shivering. I could feel the vibration. And that touched me. I started asking myself, why will a woman be degraded, be dehumanized to this level? Simply because she was wet. For her, she was smelling. For her, she was nothing. For her, she shouldn't exist. For her, no. So that made me to say, woman should not suffer because women are gold, We are treasured. Yeah. Just like any other human being. And to know that what they are suffering is preventable. It shouldn't be. So that's one of the things. If you touch me with this, I can go further. Again, these women, when you meet them at that early stage, they consider themselves lower than they sit. A woman came to my office in a town. I offered her a seat. She looked at me and looked at the seat and looked at herself. And she preferred to stand. So I said to her, please sit down. She sat at the edge of the seat. And within 5 minutes, she would look at the seat. So before we finished talking, she got up fast and looked at the seat. She was considering the dignity of the chair more than herself. Because she knows the seat will be. I can go on and on and on this. The simple answer is that my experience coming in contact with them, if you do, it will change your life. Thank you.
Thank you. We do know that obstetric fistula and VVF used to be an issue that impacted us in Ireland. It impacted women in America in great numbers. It impacted women in the global north. But at the moment, we know that primarily it is concentrated in parts of the global south. Why do you feel that is?
Thank you, Nadia. Yes, VVF used to be a global issue, a burden that affects the whole world. But now it's more in the African, more down south, as you rightly said. Even a renowned professor in VVF, Professor Sunday Adoye, in his last speech, shared that Nigeria shared 40% burden of VVF. So 40% of the burden of VVF alone in Nigeria. And as you said, have it, even UNFPA, that you have 150,000 backlog cases. You heard them talking about women waiting. So you still have about 150,000 waiting. And this is not because there's no way they would have counted everybody.
Right.
And we're also meant to know that every year you have 12,000 new cases. And out of these 12,000 new cases, only about 5,000 to 7,000 are being repaired. So you see that more are being added every year. But your question is, what causes this? Now, let's look at it medically. Under the medical aspect of it, what do we have? Who do we have? For a woman to have a self-birth, a total care, there must be facilities available. Now, do they have the hospital? In the south there. Like you go there now, our health system is going down. Why? Even in our hospitals now, you cannot get enough staff, qualified nurses to work. The ones trained out looking for greener pastures. So the health system is going down more and more. And then the ones trained, when the well-trained, experienced ones are out, who remains there? is somebody that is not experienced. And then, if the hospital is there, is it accessible to the woman? Can she go there? And if she can go there, can she afford it? And if she can afford it, will she be attended to? That's going back to the facilities, having equipment. Are there equipment there? We have a lot. Talk of structurally. Under structure or social, how free is this woman? Can she come out? Is the road accessible? How peaceful is her environment? Can she interact with others? You can also look at it economically. Is it viable? Does she have enough cash? So there are many factors that can affect, that are causing BVF to be a burden to Nigeria till this day. Poverty. Talk of education. Under education, down there they will tell you if you have a boy, you are this. If you have a girl, you are, but all that. So male education is still more valid. As I speak to you now, I know a girl that had VVF when she was 13. Till now, she has finished secondary school, but till now, she's waiting for her senior brother to finish university, in the higher school before she will get in. And the girl's woman, time passes.
Yes.
So, are they educated? And then, how many people are aware of VVF? How many people know about VVF? When I went to Akwa Ibom first, we went to the ministry to talk about VVF. A highly respected person there told me, there's no VVF in Akwa Ibom. I opened my eyes and looked at him and said, is this man dreaming? When we have cases, all we did was to invite him, say, please, come and visit us. And he came and saw. So there are many places VVF exists. People are not educated. Awareness. I was happy hearing Maria still talking about awareness. We need to create a lot of awareness for them to know. So there are lots of things we can do. And this lack is why VVF is still a burden. And I'm afraid it may even increase because of the way things are going in Nigeria.
Yes.
Thank you, Mandy.
Yes, of course. You are such a fabulous advocate for these women and girls. It's amazing. And I saw a statistic recently, which Jacqueline shared with me, that for girls in South Sudan, there was a higher probability of them dying in childbirth than finishing secondary education. So that is really what you're saying is so relevant, And what you're also saying, though, is that obstetric fistula and VVF is so much more than a medical condition in how it affects the girls and women, would you say?
Definitely. It's more than medical. VVF affects the whole human being.
Yes.
Medically, this woman is sick. She's not well. To start with, most VVF patients would have lost their babies. They are traumatized. And you know what VVF does? Because of that constant leakage, a woman is bound to protect herself. And more, it happens to people that cannot afford Pampers. So what they do is to use pieces of cloth to pack themselves. And those of us that are women, you know how we feel. And once a month, you go through your time, being conscious, am I wet? And even mothers, you know how a baby feels when a baby's pampers is wet. Then not to imagine a woman that carries this year in, year out, without having a hope if this is treatable, if it can be repaired. So when they put on this wrapper, what happened? Urine is acidic in nature. And the urine on the cloth will begin to ferment. And when they start fermenting, it gives this offensive odor. And why? And that is why they feel, and they are smelling, that they want nothing. And not just that it's smelling, the corrosive nature of this urine would begin to eat up the tissues, the soft tissues. And when that happens, you know what? Microbes, germs, will settle there and begin to eat. And that's why you have what we call ascending infection. And so it affects the woman internally. Most women, it affects their productive organs. So they will not be able to produce anymore. And all sorts of things. So this is just medically, we don't want to touch. Is it psychologically? When a woman, we only see herself as nothing but what that whole called VVF. That's just the narrow definition. I am nothing. I cannot. Nobody can live with me. I can. So psychologically, it takes them off human. It makes them feel worthless and useless. No one can live with them. Nobody can. Association, they are isolated. They are, you talk of, they are traumatized, So it's not just medically. Economically, a woman will not be able to continue with the activities, the income-generating activities. Most women with VVF, they dodge, they hide, they don't come to church, they don't go to market. So how will a woman, and then they will be depending on give me, if you give me, I eat. So they are brainwashed, just to say you are worth nothing. And then this woman, most often, they are separated. Because once the condition is like that, what the man will do is go your own way, the clean man, So the woman will either run to the family, and the family will say, no, not at this time, go. And so they run. They are just isolated, discriminated, denied. Every D negative, it goes with them. I know a woman who, she was married. The first pregnancy, of course, the mother-in-law said, you cannot go to hospital because here we have to deliver with So this woman, at that first delivery, she had VVF. And the man tolerated it for the first month, this and that. But they smelled in the house, because they couldn't afford Pampers and hype, the film and the rest. So the man said, I cannot continue with this. You have to go to your family. Go. The marriage is over. On reaching the family said, no, go back to your husband. This is not how you were when you went there. So she was caught in between. She went back. And what did the man do? Okay, you have to be sleeping outside with at the corridor with mats. So she got the mat. Then and then the man brought in another wife. And to make it worse, she passed and said, this is my wife now. You can do whatever you like. I mean, you can imagine the humanization. I mean, the VVF can do a lot of destruction.
Yes.
And that's why we are saying VVF should not be held. It should be completely out of existence.
Yes, absolutely. There was a research done, and the BBC reported that a woman dies in childbirth in Nigeria every 7 minutes, right? So that number is really alarming when we think about that, right? Of how many who maybe don't die, but they survive, and they're, like you said, it's like a death sentence almost, where they've lost everything and they have no dignity and they have no hope. So would you say that you're observing that obstetric fistula or VVF, with the risk of getting it, is it getting better or worse? What is your perception of that?
Thank you for that question. It should be getting better, but I'm afraid. In 2003, UNFPA launched a campaign called End of Fistula. 2003 till now, it's still running. Although the outcome of that is that about 140,000 people were operated in Tanzania, Ethiopia, and other places. And the United Nations now launched a set of activities for an International Fistula Day to end fistula. And this is creating awareness, advocacy, and the rest of them. And they are hoping it will end in 2030. And this has made a lot of people, more people, to know about VVF. But the question is it having effect? Yeah, medically, I take an example. Like we, Medical Missionaries of Mary, we create more awareness. People are hearing about it. And those that sustain injury are coming out. But there are certain things we could not do alone. poverty is still at home.
Yes.
And with the type of breakdown in system at home now in Nigeria, I'm afraid VVF is going to increase. Why? Many girls are out of school. Take, for example, in the north, people are on refugee. They are driven from their homes. The so-called rebels, or what do you call them? Bandits, rep, So people are displaced. And when they are displaced like that, it reduces their hope. So they are very vulnerable and anything can happen. And then, talk of those that were able to produce food, they leave their homes because of insecurity. And so they are not there. And so poverty is coming home more. At home now, before I left, the cost of living has tripled. And many people cannot afford it. And so what will happen? Those in school, I met a girl who sold Fanta and bread. Fanta and bread. I was driving with a driver recently. So I saw two men, a man and a woman, pushing a girl. I just said, driver, wait. Let's find out what did this girl do. They went there. I stopped. Hey, don't come here. It doesn't concern you. I said, no, I just want to greet the girl and find out what did she do. Is this something we can? She stole Fanta and bread. So I said, she must be hungry.
Yeah.
That was my first reaction. She must be hungry. We don't want you now to judge. So I listened. Then I said to the girl, I couldn't talk then because they were, aggressive. So after some time, I said, please, can you just give me a minute? Let me just ask the girl.
Yeah.
I called the girl. I said, but when did you see her now? My sister, what did you see? She said, I was hungry. My mother is sick in the house. I went to school without food. So I was coming back and I was hungry. I ate that and then I just took that to eat. And I didn't finish it. I have some in the bag. I want to go home for my mother who is sick. I felt like weeping. So all I did, I said to her, please, I would like to see you. I gave her direction where we are living. Nadia, this is just one.
Yes, of course.
There are many girls in school that cannot continue now the way things are going.
Yes.
And when they are out like that, they are vulnerable. Anything can happen.
Yes.
And then you talk of one that will come out and a man will say, I love you. I love you. You show them little love. They follow you. Why?
Yes.
Because they are vulnerable.
Yes, they're vulnerable.
So your question is, before I will go further, your question is it going up or down? Medical people are fighting, are doing a lot to say, let it go down. But I'm afraid, unless something happens to increase the way to make the living condition better, it's going to go worse.
Yes.
Yeah. And medically, things are going down. The Japan syndrome, many people are going out. So the TBAs are the ones, the unskilled birth attendants are the ones available. And then poverty, I think.
Yes.
Do it.
Well, for your final question, the theme of the conference is hope, healing, and a world without obstetric fistula. So this is your moment to pitch everyone on your dream of a world without fistula.
Thank you so much. Thank you. The topic there said hope. So I asked, what is the hope? The first hope here is the hope, the trust, the belief given to us, somebody like me, Nadia and Jacqueline over there, by our congregational leader, Sister Osman Sharp, who thought something could be done, who thought the condition could be better. So that is the first hope I talk about. And it's the same hope we have on you, all of us seated here, and those listening to us online. We have that hope and belief in you that this time, this gathering, this conference is not just going to be swept under the carpet, that something is going to happen. No matter what it is, you have something to contribute. No matter what, how little. If you are not an advocate, you work for prevention. If you're not working for prevention, you work for you treat. If you're not treating, you rehabilitate. If you're not doing that, your pocket can speak. Your word can go. Your love can go further. That's the hope we are talking about. And we're talking about giving hope to these are hopeless women. Like that woman I was taking to the ward. The first question she asked me, is this repairable? Is this treatable? Am I the only one having it? I said, you're not the only one. There are many people having it. Until I took her to the ward. She believed that that was the end of her life. She was not going to be fine anymore. But until after repairing her, come and see the joy when she came to the house. The first one she said to me after the repairs, she came and said, I am now a woman. I said, you have always been a woman. You know, Vivi didn't take your womanhood. You have always been a woman. You are a pretty one. So my hope, my dream is that all that are listening to us today, we put a hands together and say stop to VVF. We will give hope to our hopeless women who are suffering unjustly. That's my first hope. Then the second topic there said healing. Of course, the healing, you can't ask now what need to be healed. Our word needs to be healed. Our ignorance needs to be healed. Our ladies need to be healed of this little idea, this dehumanization. Their dignity, their lost dignity need to be healed. We need to tell them that there is hope. We need to smile. We need to give them that smile again. See, the sun is shining, like everybody is smiling. Our sisters are in dark. They are not seeing. We need to smile out to them and give them that healing. And we can do it. No matter what thing you contribute, there is hope. That healing will come. And then, the last one said, word without fistula. Can you imagine what that word would be like? Can you imagine? I have a dream. I have a dream to see those women that are waiting to smile and say, God has remembered us. Our time has come. And it's possible. It's possible through you and me. You see how we started?
Yes.
And I want to use this opportunity to thank especially Nadia and Jacqueline. You are two great women. Sister Osla had the dream. The dream would have died. She had the dream, she shared it. And two of you carried it. And I was consulted. Being something I have passion for, because if VVF finished today, if there's no VVF in the world today, and I have my first breath, I'll go straight to heaven because I know.
I think you're going straight there.
That's my dream, to see these words. And so that dream she had, many have been dreaming, as we said, UNFPA, since 2003, they have this dream that VVF will finish, bring it to an end. And it's still on. So when we will all work together and bring VVF to a close, I don't see why God will not feel good to us to say, well done, our beautiful women. And it's the same hope we are having on everyone here. That one day, our ladies will smile to say, God has remembered us, no matter what.
No matter what. Thank you so much. Thank you very, very much. Thank you so much. Well, you can see why we wanted to speak to all of you, can't you? She's so knowledgeable and passionate about this. We deeply appreciate it. We also want to thank the other coalition members, Amrai and Mission Cara, especially Jennifer and Claire and Megan and everybody in the room today with us making this possible, and also Father Edward Flynn, who has been massively involved in this since the beginning. We are very grateful, and Irene Carson as well. So many people who have made this possible today and for the last couple of years. So we're very, very grateful for that. At this time, we're going to move over, and Jacqueline, who is here for us, is going to share some specifics with you, and then Dr. Shane Buffett. Thank you.
Good morning, everyone. Sorry. Thank you, Sister Sylvia and Nadia. It's quite hard to follow someone like that with the passion that Sister Sylvia has had for obstetric fistula for decades, really, isn't it? So I'm going to talk to you about the coalition, the SafeBirth4All. So it was established a couple of years ago, and it's Irish-led, and organisations and people shared, united by a shared hope for a world without obstetric fistula, and women having the right to access a safe birth. Together, the partners straddle the spheres of global health, human rights, international development, and religious life, working with local members or partners in the Global South and through various national and international actors up to UN representative bodies. So why the PART framework? Well, we're wanting to part with obstetric fistula forever. We want it eradicated. So the PART is prevention, advocacy, rehabilitation, and treatment, the 4 pillars. And what does the framework support? Well, it supports a shared identity for the coalition members and partners. Our focus is united. It reflects the continuum of care, and it extends beyond treatment alone for women with obstetric fistula, with VBF, to prevention before that birth injury occurs. Multi-level advocacy for attitudinal change, behaviour change, visibility of obstetric fistula, and investment to prevent obstetric fistula and promote a safe birth. Treatment and specialist care for women with obstetric fistula, VBF, and rehabilitation and reintegration after a birth injury occurs, and hopefully after they have been treated and repaired and are dry. It supports donor engagement. So the coalition is not a donor. Instead, we seek funding from others. And it supports collaboration. And hopefully one of the things today we can look at in small groups later and discuss in the room and online is, how do we collaborate together? What do we do to bring about a change in the lives of women with obstetric fistula and girls and women at risk of obstetric fistula or an unsafe birth? So I'm going to look at 2 pillars, prevention and advocacy. I don't know if I said that. And Shane will look at rehabilitation and treatment. So we're looking at it with a focus through a lens that is human rights, human dignity, like Sister Sylvia talked about. And it integrates the wider social, economic, gender, cultural, and health dimensions that contribute to the birth injury. So when we're thinking about prevention, and advocacy, we're thinking with a very wide lens of what we need to do to contribute to change that is effective and meaningful. Continuing to do the same things year on, year out hasn't really brought about the change we wanted, not in Nigeria anyway. Now, I'm speaking from what we're doing in Nigeria today, but obviously the coalition is much broader than one country, and MMM is much broader than one country. So we're championing social, systemic, and structurally transformative change, locally, nationally, and internationally, with advocacy and mobilisation, with different coalition members focusing on where they're best placed to advocate for women and girls. And we're here to strengthen the profile of safe birth and obstetric fistula as urgent health, gender, and rights-based issues. So, where do we have hope? Where can we work in terms of prevention? Now, this is just a few ideas. In the room, online, I'm sure you should have many more. So we're working on prevention-focused research. For ourselves, it's been some context mapping. Increased awareness on safe birth practices. Healthcare provision that facilitates safe birth. training of healthcare workers and frontline workers like our TBAs or traditional birth attendants, community health workers, and systems strengthening through referral pathways and early risk identification. So what did we achieve in 2025? Now, this is a snapshot. It's not everything, just a snapshot, because I've been given a very short time to talk to you. And it's only involved 7 projects, 7 ministries in Nigeria, 4 of which have are health facilities where a woman can deliver a baby, and the other 3 are not. They're more community-based programs with some health centre facility and support. So we increased awareness in safe birth. So one of the interventions of many was that 313 women accessed a WhatsApp platform to support safe birth messaging. Why? Well, how many of you have turned to Dr. Google or a chatbot and put in your symptoms with do I have COVID the last 6 or 7 years? Do I have, well, let me tell you as a woman who's been pregnant, you're very tempted to go to Dr. Google, but you might not get a discerning or the right response from that. And women do it all over the world. People do it all over the world. So this was a way to ensure that women were getting the right messages around risks, around birth preparedness, reminders to attend antenatal, reminders to come to hospital for a safe delivery. The WhatsApp group is managed by our staff, or midwives or nurses, where a woman who has a question, if they've got an issue, can ask the group and get an immediate response. So if she has a concern, it can be addressed. They can follow up with a phone call. Come in, you need to come in now. Or it's okay, this sounds fine, but if there's anything else, come in to us. It also offers peer-to-peer support, so women supporting women. That their experience, what they're experiencing, they can encourage and support others. And it's been a success. And this was an innovation that one project started in 2025 and is now being rolled out to other projects as a result of learning within our action group in West Africa. Earlier identification of labour complications. So we're working with the TBAs, traditional birth attendants, in a number of projects. Now, the average rate of TBAs referring for a facility birth where there are risks is 13.48%. Now, that sounds quite low, but really when you're starting from 0, it's progress. Because we're asking those TBAs to change their knowledge, change their attitudes, and change their practice. And that's not easy for anyone. What we found in the 4 projects that were engaging TBAs is that one only had a 3% increase in TBAs referring, whilst another had 36%. So there was a lot of good shared learning there about what type of additional support that we could be giving to TBAs to increase referral rates. So, for example, in ETAM, it's not a once-off. Talk to a TBA and that's it, change happens. It's a continuous learning, education, and most importantly, accompaniment. Listening to the TBAs, hearing their stories. And through that, we found that TBAs were themselves stigmatised when they went to a health facility by the staff there. So we then had to work with the staff in the health facility to reduce stigmatisation of TBAs, to ensure that they then felt comfortable bringing a woman to the hospital. So it's looking about the whole context, that localization, that communication, that feedback, to ensure that change can happen. Promoting stronger community and facility readiness. 172 health professionals were trained to promote safe birth and reduce obstetric fistula, and 7 facilities were supported to improve maternal and child health services in line with government policies and standards. 2,336 women accessed a safe birth in those 4 facilities. So we're reducing preventable childbirth injury and mortality. And the prevention-focused research on context mapping. So we mapped 3 sites one an urban slum area where there's no, where we're not offering full maternity services, one a larger general hospital, and one a maternity hospital with the VDF to see, well, where within those sites are we doing good work to ensure there's safe birth, and where are there gaps where we could be doing more? And those 3 sites threw up different recommendations for us. And it's a tool that other members, other people, organisations in the room can also utilise as well. We're finalising it and the user guide as we speak. So it will be available, and we're happy to be sharing that with folks. I'm actually going to skip that slide because I know we're kind of running a wee bit behind time. I'd like you to introduce you to Alani. She is from Aleta, Ibadan, Nigeria. The video I'm going to show is a very short clip. It's not the best quality. So look and actually just read what's on the screen. And I'm going to talk to you about her afterwards.
I used to be well with CPUs. But sadly, I lost CPUs. During sensitization of safe order option in my mother's legal government, my mother-in-law advised me to register with certificate. And here I am today, healthy and alive.
Okay. So there's a mother who's got her newborn baby, and she delivered in St Mary's, which is Oyo State. In Oyo State, the incidence of obstetric fistula is 1.4 women in 1,000. And the maternal mortality rates range from 346 to 756 per 100,000. One woman dying is enough. One woman with obstetric fistula is enough, but this is much higher. This Alanji lost 3 babies before she had her first live born. Why? Because her mother-in-law heard about the need for safe birth. Her mother-in-law brought back that learning, that awareness, and advocated within her family for Alani to attend a health facility for a safe birth. She listened, she was able to advocate for herself, and she has a baby. And she wanted to share her story with you here today to show that it is possible. And preventing maternal mortality is possible. So I thank herself for sharing her story with us, and the staff and sisters in St Mary's for capturing it for us. So, advocacy. From grassroots to UN mechanisms, the whole gamut in between. So when we're thinking about advocacy, what do we want to do? Well, we want to promote safe birth and eradicate obstetric fistula through increased international lobbying, integration of national alliances working together, and community-based or initiatives or person-centred initiatives at local level. So every single level. So some illustrative areas of work, just some, a snapshot. Community-based initiatives, policy, systems, and structural engagement at national and international UN levels. Coalition advocacy together. Together we are stronger. Our voices carry more, will be heard. Participation in relevant forums and events, Mission Cara member guidance and internal mobilisation, webinars, shared learning, communications, donor engagement. The list, I'm sure, goes on, and you can think of many more than I. So what have we achieved? Well, through the work of Rights Proof and Edward Flynn, there's been submissions to UN mechanisms and bodies to promote safe birth and the eradication of obstetric fistula. There's been 2 national level initiatives to promote and support safe birth and the eradication of obstetric fistula. To give an example of one, the 2nd annual Angolan conference around obstetric fistula was held with over 80 attendees with cross-sector participation from many different actors in Angola that are working to address this. There's been increased integration of alliances working to promote safe birth and eradicate obstetric fistula, so VBF. So in West Africa, the MMMs have set up the Safe Birth Action Group, which is a 30-member with 12 projects across 3 countries, and with additional persons with individual interests engaged. Now, note the word action group. The sisters and staff were very keen that it wasn't a talking shop group, it was an action group. So actions that they've taken was talk to 3 people about safe birth and obstetric fistula, a minimum of 3 people. What do you learn from that? What's people's awareness? What's the barriers to safe birth? What risks do they have for obstetric fistula? And we find girls at risk of teenage marriage, early marriage, that shared those concerns. And it's just one. And those projects have all decided to launch their own small prevention project. And that's basically being determined by the staff and sisters in each of those projects, not by us in this room, by themselves. So a snapshot of what we've been doing at community level. So 306 TBAs are engaged to strengthen referral pathways, for promoting safe birth, preventing obstetric fistula. 205 community focal persons are engaged to strengthen referral pathways again and increase women's confidence in seeking skilled care. 234 community and women's champions have been trained to address culture and gender barriers affecting really not just maternal health. Those women's champions are looking at, do teenage girls know about their bodies and know about what happens to them? For mothers or grandmothers who are maybe the decision makers in a family about where a woman is allowed to deliver, are they carrying intergenerational trauma? Does that need to be addressed? So really looking at, well, what are the underlying factors that cause an unsafe birth or a fistula occur? 17,550 school-aged children were involved in school health, safe birth, BVF awareness raising and reduction. And then 674 men were engaged in dialogue to support safe birth and promote gender equality. So when you're looking at advocacy and you're looking at prevention, you're looking at the grandmothers, the mothers, the women, the girls, the boys, the youth, the men, everyone in society. So where do you fit? Where do you fit? Where is there hope for the way forward? Are you working in school health or with out of school youth, girl-child education, maternal and child health, community-based programs, UN advocacy, funding? We would like your support. Mobile health and AI. Sylvia talked about the JAPA, the brain drain. You've trained your doctors, you've trained your staff, you've trained your midwives, and then they leave, often coming to our shores to work. But what does that leave there? And maybe we need to be looking at more mobile health and AI to support the work that's happening there where possible and realistic. Communications, storytelling. Are we gossiping about obstetric fistula to others? Are we talking about safe birth? Are you a researcher? There's more work to be done. Are you an M&E specialist? Are you working with girls with GBV and you've got excellent monitoring tools? Could they be shared? Think broad, think wide. Are you in government and you're looking at revising gender policies, child policies, education policies, MCH policies? Is there a working group? Can people get involved? Are we training frontline workers, healthcare workers, community workers? Where can we partner locally, nationally, and internationally together? Are you engaged in solar equipment? Because having delivered a baby with the light of a head torch, it's not easy. But if you can turn on a light and you've got power, it makes it a lot easier. influencing. Are we influencing those around us, and who can we be influencing? And if you're here in Ireland, are you raising awareness for women that may be coming to Ireland, arriving with obstetric fistula? And are we ensuring that our Irish healthcare workers know of obstetric fistula as well? And that is me. I've stopped talking now, and I'm going to hand over to Dr. Shane Duffy. Shane is an obstetrician and fistula surgeon in Chelsea, Westminster, London, and also fistula surgeon visiting in Kitovu, Uganda.
So many thanks for the invitation to come and speak with you today. I'm delighted to be here amongst many friends and colleagues. And I, as Jacqueline said, I'm an obstetrician gynecologist based in the UK, but I've been involved with Women's Health International for a few years now. And I've been honoured to be trained and mentored by some inspirational people over the years. And I started off in Ethiopia, where I was working in a rural hospital in Ethiopia, and many patients were coming to the hospital with this condition called fistula, which I was unable to treat or didn't have the surgical skills. And then I met a man called Dr. John Kelly, the late Dr. John Kelly, who's a friend of many of us here. And he inspired me to get involved with the work. And then Dr. John introduced me to Sister Dr. Maura Lynch. And that's how I got involved with my friends and colleagues who are online, I hope, in Uganda. And I've been working there for probably over 20 years, learning, but also now teaching others how to repair fistulas. And it's a challenging job. And I think one of the challenges that we will talk about is about the challenges in terms of providing this treatment, because it's not an easy condition to treat, which is part of the problem. So I, like Jacqueline has gone through, I was delighted when the SafeBirth4All Coalition started, because many people were working in silos, I have to say. And part of the challenge of us not reaching the targets to eradicate fistula is partly because we are all working in silos. And as a doctor, I realized that, yes, I can do the surgery, but no matter how quickly I do the surgery, there's lots more coming. And the prevention and advocacy that Jacqueline has so eloquently spoken about is almost turning down the tap to preventing people coming. But then when they do have the condition, it's also very important that we also provide treatment and, dare I say, rehabilitation, because many patients have been through very traumatic episodes, and I have to say the videos were very powerful. Over the years, I've seen many patients come through the organisations where I work, it's a bit low. Sorry. Thank you. And I realised that the institutions that exist also are supported by many people who are not working in the institutions, and it's really nice to be here amongst many people who are friends and family of all the organisations. And I was looking at the participants who are part of this meeting today, and the strength of it is not just people who are here in the room, which I have to say they're formidable people, but also the people who are not only here in Ireland, but in the UK. We have many people online in the UK. And we've also got people from America who have engaged with this process, but also are people making change a reality. And I was looking through our participants list, and I could see that we've got people from Uganda. I've just talked about the fantastic people at Kitovu Hospital who are making change a reality. They provide over 500 surgeries a year and have been going for over 30 years through the MMNs initially. And now the local sisters run the Mission Hospital there, and I have to say it's been doing fantastically well. And I'm grateful to them and all their hard work and the surgeons, and there's a big team that they've got working on this. We've also got people on from the Congo, and Dr. Lucien, who you will meet in the facilitators groups later. He worked at Kitovu, and dare I say, now is a fantastic light in the Congo, where not many surgeries were happening before he arrived. Now, I think he's done over 1,400 surgeries since he started in 2021. And I have to say, I'm going to sing Dr. Lucien's praises here, but he's an inspirational chap, and I hope we'll get the chance to hear in the facilitators groups a little bit more from him a bit later. We got people on from the Angola, Tanzania, Kenya, Nigeria, Sudan, Zimbabwe. So I am delighted that not just the people here, but also the people online will be able to help talk about their experiences and their solutions moving forward. And I think that's the idea about this conference, which is not just to tell you about the work that we're doing as a coalition, but also to think how we can accelerate and do more. And Jacqueline has talked about the first two parts of the pillars of the framework that the SafeBirth4All Coalition have adopted. And I'm going to talk a little bit about rehabilitation treatment. I have to say, I don't know who came up with the parts framework, but it's actually inspirational. I don't know where you got it from, but the Latin for parturition is a Latin word coming from partire, and I don't know whether you knew that, but so the part framework, obviously parturition is a fantastic, and we're all about safe birth, and I think it's a fantastic way to look at how we can be making sure we've covered all aspects. And there's people with different expertise in this room and online who've got areas specifically in these areas, and hopefully we'll learn a little bit more about their experiences. And birth obviously is a natural phenomenon, but it involves stretching, and the genital tract needs to stretch in order for a baby to come out, and that's normal, and that involves tearing, and over 80% of people have tearing. Mostly some sort of suturing to repair the tear. And then you've heard on the ladies there speaking about the challenges with severe tearing, and anal sphincter injury can happen in around 2.5 to 11% of any normal birth. So that's tearing that goes to the back passage, and if that isn't repaired, then that can give rise to anal incontinence. So when people talk about natural childbirth, it can be fantastic, but it also can be unforgiving, and it can give rise to significant morbidity. And when those percentages there are ranging from both in high income, but also in low income, so it doesn't distinguish birth, whether it's here in Ireland or whether it's in Uganda. The same tearing and stretching happens, and the risk factors for these tears vary. But if you have an instrumental delivery, they can go up to around 11%. But also in the front part of the genital tract, the stretching happens where the bladder is, and that can give rise to incontinence. And believe it or not, 40% of women can experience urinary incontinence either in pregnancy or after childbirth because of that stretching. And some of it can be long-term. And then we're all here today to talk about that, and also to talk about the more severe end, which is being left with a permanent hole. and if you're left with a permanent hole, it's a fistula, and then trying to repair that. Obviously, we're going to talk about it a little bit later. Now, Timothy Kintu, who is an inspirational young doctor I met in Uganda in March, and he sent me this paper last week. So this is a paper that came out about perineal trauma in Africa. He's a young doctor, and Timothy, I hope you're online. And you're probably not expecting me to talk about it today. But the reason I wanted to talk about this was, first of all, he gave a very nice overview of the numbers of women in Uganda and in middle and low resource countries. And he gave a very good overview. But also to talk about him, which is the future of where we're at in terms of how we have to deal with this. And Timothy is a young doctor who's trying to develop an innovation to try and reduce perineal trauma. So there is hope. And when I met with him in March, I was inspired by people like him. And also there's many people online. I don't want to just name out just one person, but there are people doing fantastic work all over the world. And he's going to test this little bit of kit to see if it works. But it's getting all these people together to try and come up with new ideas, new ways of thinking, and then also about how we communicate it to each other. Because I think, as I said, sometimes we work in silos. So having forums like this where we can meet, think about new ways of looking at things, but also hear from each other's experience, I think are pretty important. So I don't have to talk about why rehabilitation matter. Most women affected by childbirth injury often experience prolonged physical suffering. So I think as a doctor, I realized that I become very focused on the problem, on the solution rather than the problem. And what's really nice to hear about, and hearing Sister Sylvia about her experience before they even get to the hospitals is really powerful. And I think the stigma and isolation and exclusion from family and community life that Sylvia has talked about, and the journey from being in labour, being alone, having a stillbirth. About 80% of the people will have the women will have a stillbirth even before they go on to have the problem with a fistula. So they've been through a very traumatic episode, both physically, psychologically, and psychologically. There was lots of studies been done, but 97% surprisingly have depression following this, and 17% have suicidal ideation. So the trauma that's happened before they even come to find out to be treated is something significant. And then when they come to the hospitals, there's barriers to specialist care, and I know we've got many doctors in line who may be able to think about their solutions and how they've actually got people to look for treatment and be aware that treatment exists. And I know at Katogu, there's Sister Dr. Florence does an awful lot of community mobilisation. It'd be really nice to hear from her experience about what works and what doesn't work, and I'm looking forward to the different groups and hearing what they thought. We were very keen when we talked about what the SafeBirth4All Coalition is doing. It's actually doing work and it's actually making change a reality. And I think that's important to be aware. And in Uganda, I've talked about the work that we've been doing there, and hopefully we'll hear online, but they treat over 500 fistulas a year, and they've been going for over 30 years. We've heard about other organizations in Nigeria. I know in Etam, they're doing fantastic work as well. And probably around many years ago, we had surgeons coming to us to learn how to do the repairs from Nigeria as well. So it would be really nice to meet my colleagues online too and greet them and hear what they've been up to. And I think it'll be nice to hear in the different groups about referral and mobilisation linked to treatment and access, which is a big problem. We know that many women cannot afford surgery, and the SafeBirth4All Coalition has funded surgeries, which we're very grateful for. It's also helped with transport and care for patients to be able to access services where there's geographical isolation and weak referral systems. So people have delayed access, and it's not infrequent that I have a woman who's had her babies in her 20s, and she comes when she's 60 in to say, I'm going to have a fistula repaired. So living with incontinence of urine or feces for over 40 years. And you would try and say, well, did you not know about the treatment? They didn't even know about the treatment, and they weren't aware that there was a solution. They didn't know that the treatment facilities existed because they went from pillar to post trying to get this treatment and given lotions and potions and surgeries that didn't work. So I don't think any of us here, well, actually some of us might, I don't make any, but you can't imagine, I couldn't imagine, and I'm a surgeon, living with this daily, and I think Sister Sylvia has tried to explain the kind of like 40 years of living with this would be unbelievable. We have young girls as well who've been raped. I had a 6-year-old recently that was raped and had a fistula as well. So it's not just obstetric fistula, but it's also due traumatic events as well that can happen. So when we have the groups, we'll talk a little bit about solutions, but I think the 3 delay model, which is a very nice model to use, and we've, as a coalition, try and look at the areas of challenge, and the first is the decision to seek care. So there will be a different group that will be able to look at that and maybe come up with solutions. How do we improve people's education and knowledge about this? And then how, when they do realise they have a problem, how do they identify and reach medical facilities, which is the second delay. And then the third delay is actually when they come to the institutions, how do they receive quality services that actually work? And the governance around that is a challenge as well. And I know we've got many surgeons online as well who may be able to come up with some solutions and what they think. And I have to say there are many challenges within the surgery as well. There will be a group, I'm sure, that will say that no matter how many surgeries I do, some patients, a minority, I can't actually get the surgery right, and maybe we can learn different ways and techniques today, if there is an interest in that, on how we can improve the surgery. Education and awareness. The reason I want to talk about education and awareness to reduce delays is that there's a large community here and online that has expertise in education. I know Jacqueline and Nadia have mentioned this. And I do think that it would be fantastic to have some solution on how we can develop an education manual on how we can improve in community education, awareness of prolonged labour, and to help reduce fistula. So in terms of rehabilitation, there's a lot happening already, and there's a lot of areas that we know work, and they involve a woman who's been ostracized, stigmatized, divorced, with no family, no pregnancies, having to rebuild her life. So when we've done the surgery, and then trying to get them to feel the hope that they can get back into normal life is important. And then I think the small things really matter. And I know Sister Winnie, who's an inspirational woman in Katofu, I hope she's online, spends a lot of time trying to encourage women to kind of get back into life and try and reintegrate. And part of that, we have a thing called the Panty Project. Many women haven't worn panties ever for the last 10, 20 years. So even just having a nice clothes to get back into and feel human again is pretty important. But also when they get back, we have to get them some skills to be able to sometimes they have to look after their own finances. So we have animal husbandry programs, teaching them a skill. We have a hairdressing program where we get people to learn how to cut hair. So thinking about how can we get them back into society and work is pretty important. And I want to talk about this, which is pretty close to my heart, and there's many people who've been involved with this. And I'm grateful for all their support. Orla, who I think is here, Orla, okay, and her family and friends, and Breda, who's sister, the late sister Dr. Mora's sister, who I think is online as well. They've been integral in trying to come up with a thing called the C-section fund, which is another way for when women come, when they have a fistula, obviously they want to have a family, and having a baby in the future is very important to reintegration and rehabilitation. And Orla has been supporting, and we will hear more about her work, for these women who had a fistula, providing a cesarean section for these women is very important. Now, accessing the cesarean section, if you can't access the hospital or you have to pay for it, they will have another baby at home and the fistula will happen again, and the second surgery is even harder to repair. So this is a really important part to preventing the future fistula, but also getting them to feel that they're getting back into normal life and having a family, which is very powerful. We have a picture in Kitovu of all the women who've had babies up on the wall. So when they come in to the fistula unit, they can see this beacon of hope, which is you can have a baby, you can get back to normal if you want. Some people may not want a baby, but it is possible. So I've been told I have 1 minute, so I'm going to go quickly. A paradigm shift is needed in obstetric fistula prevention and care to eradicate fistula by 2030, which is the aim of the UN. So we are here together. We are here to try and make this a reality, and I am looking forward to the next steps, which is your voices. We're going to break into groups after a small comfort break for 5 minutes. So for those online, I think we've got a 5-minute break, and then we're going to break into small group discussion. And in that discussion, there's going to be, you'll either be in prevention, advocacy and prevention, or rehabilitation and treatment. We're going to break into virtual groups, and there'll be around 10 to 15 people in each of these groups. And we have our tech team who's working hard here, who's going to hopefully identify how you can get into those groups. If you have problems, then please do put in the chat about how you can get into one of those groups if you have problems accessing it. And we're going to then have a small group discussion for 30 minutes. And in those groups, we're going to, I want to not just hear about your problems, but also your solutions that you'd like to ensure that we can then feed back to the group afterwards. And we're going to have a selection of around 6 groups who then provide some feedback. So it's very important that you do document your thoughts and ideas from those groups, and then we'll have some final takeaways and next steps. Now, in the four groups, there's prevention, advocacy, rehabilitation, treatment. There's also, I'm keen that we also talk about the cross-cutting areas, which is innovation, collaboration, shared learning, research and education, and the funding and resource mobilization as well. So if you've got areas specifically around those, it doesn't have to be about the part bits, but please do feed those back into the groups as well. Was there anything else that I've missed before we move on to the next bit?
Online facilitators put comments into the chat.
Okay. Okay. Yeah. So for each group, for the virtual groups, we have facilitators in each group, and they will identify somebody who's hopefully going to take some notes in the chat. So they put it into the chat as they're having the conversation. But also then you will also get somebody from your group to nominate somebody from that group that will hopefully feed back as well in the feedback session. So I appreciate it's in this world that we live in where actually it's easier here in the room virtually. We'll see how it goes, but I'm looking forward to engaging you, and I'm just sorry that we don't have everybody's face up here of the lots of people from all over the world that are speaking. I'm really looking forward to hearing your thoughts, and we are very grateful for your participation today.
Okay, good. Is it still morning or is it afternoon? Good afternoon, everyone. So our group looked at advocacy and prevention. Under advocacy, some of the things we identified was education of the youth, and that obstetric fistula and safe birth promotion should be part of every single project. It doesn't matter whether it's livelihoods, whether it's GBV, whether it's men, it should be part of every single project that we're working in, not just health-related projects, as this issue is driven by more than just health. Mobile health and the greater use of mobile technology in terms of reaching out to others. Influencers and ambassadors. So do we have people of note? Do we have influencers on social media, Instagram, that could be promoting SafeBirth4All in Ireland, in the UK, the States, Nigeria, Tanzania, Uganda? Who is online that could be an ambassador for us? Bringing in the youth. Because they're so online. Social media is a big part of their lives in particular. Greater UN advocacy with a thematic focus. And then CSR program opportunities. So where there are lots of medical companies in Ireland, is there any opportunity to dialogue with them to see if we could be advocating for additional funding for SafeBirth4All? And then widening the coalition, so increasing the number of partners and collaborators together, but also replicating this model that we're discussing in the room beyond what's here in terms of the sharing and the learning and so on and so forth. So that was under advocacy. I'm hoping I haven't missed anything. If I have, apologies. Under prevention. So the group acknowledged that when you're looking at prevention and you're looking at advocacy, there are two, legs on the same person really, because you need one for the other. So prevention, discussing safe birth, discussing obstetric fistula at every level within the community. Looking at opportunities for AI technology in terms of health and reaching out to people, mobile messaging. Reminders for appointments, reminders about safe birth preparedness, all of those, that type of technology that could be there for us. Stressing the responsibility of men in terms of safe birth and safe birth promotion. education, education, education. For the youth, boys and girls staying in school. North-South collaboration for universities and hospitals collaborating with Southern partners to support training needs, education needs, research, and so on and so forth. So that was it in a very brief nutshell, and I'm going to hand over to yourself.
Thanks indeed. Myself and Edward and a group of professionals at some form. And the first question we were answering was what to say with this, what to move this, what to serve. It's about what we heard this morning. And what we noticed on the table when we made the introduction was that people had come from all over the thing with all sorts of experience. And even some would say, I have no experience. What can I do? What can I bring to this? It kind of struck me as something that was worth mentioning at the very beginning. I suppose in a lot of ways, something that we spoke about education, advocacy, raising awareness, how to do it. And we spoke, I suppose, very much at the very beginning, we spoke about the disposal and how it seems as though women are isolated, that they're disenfranchised, that there is a gender issue, a rights-based issue, and that Ireland has a very, as a confident country, is well able to stand up for those who are disenfranchised, and they have a good record of doing so. But that perhaps for the leverage that, if you like, that concern for the other, which Ireland is very, very good at doing, and leveraging it in a way that we can make a difference somewhere else. Ireland, I don't know whether people are aware, Ireland negotiated the Sustainable Development Goals. That was in 2015. So it was our ambassador, David Donoghue, who brought them. So not only that, we always made a bigger game out in the field than our size might, if you like, announce that we could do. So that point of view, we are saying that Ireland could do a lot better, or that Ireland could do more than it might be expected. We like the idea of the whole the notion of part. And we thought that it was done very well. We listened to Shane and we spoke about what comes in between the various words of part, the acronym, the collaboration, the education, which was mentioned earlier. With regard to advocacy, we mentioned, for example, Ireland will be examined under the University we all have to do this year. And this is one way in which Ireland can speak to the human rights record, not just of Ireland, because Ireland, like others, but in particular Ireland, also believes that we don't have enough responsibility for ourselves, but also for its way. When we negotiate the Sustainable Development Goals, we believe that we would look after those furthest behind. We would ensure the needs are behind by reaching the furthest first. And in doing this, perhaps this is one particular issue where we can champion that particular idea. The UN mechanism, the University Review is one program will be examined on this time of year, and 2 years' time we will be examined on the Convention that divides job and then on the social and cultural. These are all opportunities whereby we can ask those countries reviewing Ireland, what are you doing for those with the sexual issue? What are you doing for the women who are left behind? Also, what we learned today was there's so much information, and we were very taken by the video that we saw at the beginning. We were very taken by Sylvia's connection to her story. And we're also concerned, for example, that funding hasn't been mentioned. We're concerned, and like some people said at our table, I don't know what I agree to the table. When we realise, for example, that to apply for funding is a specialist skill, and demands that somebody knows intimately the issue and how to access the funding, because it might be a nuanced application gets most funding. So it can't be anybody who will do it. So it can be quite a skill to put together all the various forms of advocacy, prevention, treatment, rehabilitation, education, collaboration, awareness raising. These are all the various aspects. But what is true, I think, this morning is that there were 111 people online. There's about 35 people here. That not only is it indicated, but there's huge confidence. And we also found too that Ireland has an opportunity this time in June. We will be EU presidents for 6 months. This comes around once every 13 and a half years when they do the maths. And there is an opportunity for us to raise the issue by writing to the Taoiseach, writing to the Department, writing to Irish State, saying, how do you bring this issue? Because Ireland is getting the opportunity to set the agenda in lots of different things. For example, the COP negotiations one, but in every aspect of EU policy over the next 6 months, Ireland is shaping the agenda. And they are taking suggestions as to what is it that we would like it to be raised. So I don't think probably we would try and maybe at first instance say, well, we think we'd like you to raise this issue, and we could do it to the various ministers. Yeah, rather than saying, with the other thing, the last thing I would like to say is that we said that if we were going to do something or to try and create greater awareness or advocacy, that it can't be once off. It isn't slow burn. It doesn't take time. It has to sustain. It might begin small and gather pace and gather momentum. But it's the gaps between the letters and parts, the collaboration, the education, the awareness raising, it's incidents, it's bumping into people, it's having the conversation. It's walking away today and saying, we're not telling you what I was at this morning. That's where the wealth of this, this is where I think this issue will bear fruit. Thank you.
Thanks very much. So a lot of the themes that you've just heard, we did actually, there was a bit of overlap as well. My name is Kathy Allen. I'm an obstetrician here locally in National Maternity Hospital. But I did have the privilege of visiting Cotogo Hospital many years ago and just working with Maura Lynch. So that's what my background. But fascinated to come along today and really honoured to join in a very multidisciplinary group at our table. We had communicators, teachers, a couple of doctors and people with providing care on the ground. But just we tried to focus on treatment and prevention, and we did identify, I guess, the importance of integrated care, that everybody has something to offer to the improvement of services on the ground, whether you have a skill set in BVF surgical repair or whether you are the person who is organising the background. So, so that there is an inclusivity in the whole programme, and that, would be, I think, a key thing for going forward, involving everybody. The mentoring and the teaching we can certainly exploit the joys of the internet and AI these days now when it comes to surgical teaching and staying on top of it, but also from an organisational point of view. We did kind of think a key theme was empowerment of individuals through education. And that starts early. It starts in primary education. It's enhanced at secondary education so that people know and can really speak and ask questions about taboo subjects, questions that might feel a little bit too intimate, but, with more and more, I suppose, comfort and general conversations about intimate, private, sexual health, that can only really, really help. I guess it's the ignorance sometimes that leads people into situations where they end up, with difficulty, and the empowerment of being able to actually seek medical help when needed is key. So primary education, secondary education, and as has been mentioned before, male education. This is a community issue. It's not purely a woman's problem. So then we thought about going forward, what can be exploited in the future to help support the collaboration. Well, certainly other groups, perhaps educational groups with women's educational platforms online or offline as well, so that access to decent education can be forthcoming. Groups like Camara and social media as well, to reduce cost and make this all very cost efficient as well going forward. So I think they're the key things. Probably a better AI summary on Shane's laptop there. But again, we overlapped a lot with a lot of the common themes. Thank you very much. Thank you.
Okay. Thank you. Okay, so at this time, we're going to go online and we're going to hear some feedback from a couple of people. The suggestions have been made that we would hear from Tony Pike, who is a steering committee member. Tony, if you're there. Okay, I think someone's unmuted themselves, perhaps prematurely. Dr. Lucienne, Sister Kaite, and Serena are the other four. So right now, if we could, I feel like the Eurovision Song Contest, which we didn't go to, by the way. Tony Pike, are you there? Tony, if not, we'll move on maybe to Lucienne, Kaite, or Serena.
Yeah, I am Nadia. Yeah, sorry. I am now. I was roving, but then I stopped at a group 2. So I wasn't there. I was there for about 5 minutes. I think the key points that I from the groups, the two groups that I was in, was around male engagement and male involvement, and the role of men and boys in ending obstetric fistula, and the importance of education in, healthcare settings, but also schools and churches.
Okay, thank you, Tony. Appreciate that. Thank you for sharing. Dr. Lucienne, are you there? We have some dodgy network connections for some people, so we're not sure. Yes, he is. There he is. Hello, Dr. Lucienne.
Yes, I wanted just to thank all the organizers of this event and all the presenters for giving us talks which are like heart-touching, and they are related. They're showing immediately the reality of the ground, because all the presenters, they showed us the pain of fistula patients. And this, we want this to be discussed with all the participants, because many people, they don't know about fistula. So that we have to increase awareness. We have to increase awareness among ourselves and among the entire community, because we need more people on the board so that we can prevent fistula, because fistula can be prevented and can be treated. So that we have to work together as a team. And this is the starting point with SafeBirth4All. So that we have to take this opportunity to go ahead and to keep it up. So that we should not stop at this meeting and we meet again next year. So that this is like the starting point, and we have to work hard so that we could have the impact on the ground and we save lives of many women in the community. Thank you very much for taking this opportunity to increase awareness among ourselves and among the community. Thank you.
Thank you so much. And thank you very much to Dr. Lucienne for all he has done. He was the speaker for our West Africa Action Group and has given us so much material and been such a great supporter of SafeBirth4All. So thank you very much for everything you've been doing and for what you will do in the future. Okay, at this time, can I see Sister Kaite? Are you able to reach us? If you could unmute yourself, please. There she is.
Sorry, do you want me to comment for my group?
Yeah.
I thought it was okay. Well, in the group, we discussed one of the things that we felt, we talked about prevention and advocacy. One of the points that came up was to work with existing power structures, existing systems in place. So one of the things we discussed was people on the ground have a lot of trust on the religious leaders, the pastors, the churches. Can we educate them to educate their people? We also talked about could we also collaborate with the existing government structure, the ministries, of health or education, so they could create a policy where these things are discussed in schools, are taught in schools as part of the school curriculum. So I think we talked about, and then to train the traditional birth attendants, bring them in so they can also use what they know now to prevent what is prevent the fistula, to give better skilled attendants during birth, during childbirth, and to refer appropriately, refer on time, refer appropriately. Those are the kind of things that we discussed in our groups, both on the prevention and advocacy. Make make the problem visible to those who need to know about it. Make it known. Like it's not enough to just go and treat it or solve the problem. People who have the power to do something about it need to know the burden of the problem, the existence of the problem, and the consequences of the problem in society. So I think we talk to the children in schools long before they even think about having children. So they know this is a possibility, an awareness, and then they take the decisions that will veer them completely off the road down to obstetric fistula or obstetric problems. Yeah. So the problem in Nigeria, and Sister Flavia said, is ignorance, yes, but there's also a lot of other hidden forces that affect the prevalence of this problem. You heard her talk about somebody's mother-in-law. If that girl's mother-in-law did not intervene, what will happen will have happened. Like she would have still had the fistula. So the other factor that we need to also consider, what is the real problem? What are the stories behind these statistics? What is happening? Why is this problem so huge? Why do we have so many people? Every time we have a VVF camp, we have this big crowd of people coming in to have free surgery. What is the why? What are we missing? So we need to talk about those things a bit more. And as she said, my colleague said, the taboo topics, what are those things we are not talking about? We need to start talking about those things so that we can prevent this from happening. Thank you very much. Thank you.
Thank you very much. And thank you for all you're doing as well for SafeBirth4All. We really appreciate that. I'm going to try for Sister Serena again. Are you there, Serena? No, maybe a dodgy connection there. At this time, Dr. Sister Nabakalu from Kitovu, are you there? Are you available?
They're coming.
Maybe. Is there another facilitator who's been online who would like to volunteer to speak? Then you can put your hand up. That would be how we're trying to do it. Is she?
Hello?
Yes. Yes, go ahead.
Okay. Speaking for my group.
Okay.
Am I on?
Yes, you are.
Yeah. So I'm speaking for my group. We discussed about prevention and education, and we look into the aspect of going into taking advantage of the community structure in terms of traditional institutions and also household units. And the need to involve women the more alongside with men concerning the fistula issue. And there is also a need for us to take advantage of the existing law of the land. For instance, in Nigeria, there is something called VAP law, Violence Against Persons Prohibition Act, and which frowns against domestic and emotional abuse, fistula and abandonment of the wife, of the woman, because of fistula is a domestic and emotional abuse. If we can take it from the aspect of the law too, it will strengthening our awareness raising and eradication of this act. We also look at the issue of taking advantage of antenatal clinics to be able to educate people the more, and even hospital staff need to have deeper knowledge about this SafeBirth4All, and in particular the issue of fistula, in order to be able to carry on the work as they ought to. We also look at the issue of the school program for us to be able to engage students who are adolescents at that level and are very active and can also have an idea or knowledge of how to manage themselves and prevent themselves from all this. we're talking about the fact that even when we are expanding the horizon of SafeBirth, there's need in the aspect of implementation for us to also put it in mind that it's not just SafeBirth where everybody is happy that yes, there's SafeBirth. But while you are happy for SafeBirth, you also know that you owe responsibility. And that is why we're saying that at the back of our mind, when we say SafeBirth, we're also saying that SafeBirth for all and by all. And that is the that is the thing. SafeBirth by all. And by all, we are saying that it has to cut across all ages, even when the child is growing. It's the responsibility of the parents, it's the responsibility of the community, it's the responsibility of the guardians. Okay, so that while they are growing, they are prevented from certain things that can cause them this havoc in future. And these are the things. So we are looking at that SafeBirth for all and by all should cut across ages, gender, and also institutions, and we'll look at that. And we was talking about also the use of media handles, where we send a lot of messages to the young generations. And these are the things we discussed. I hope I've been able to capture everything. Collaboration with some government structures that can help us to further this cause. And that is like, for instance, the Ministry of Health, even the Ministry of Social Welfare is also part of it, and also the Ministry of Justice also that can help us. It's not that we want to bring people to book under the law, but that to be aware of the fact that there is a law that exists that prohibits them from abandoning the woman. It takes two people to bring about pregnancy, and only one person, when fistula happens, only one person bear the brunt. And this is where the issue is. In order to stop that, it will now have a kind of impact on those who are into abandoning their wife and know that they have to come together and join hands with the institution that be to be able to rehabilitate the woman. And that is without ostracizing or isolating. And these are the things we discuss.
Thank you so much. I think he's right up there with Sister Sylvia's passion for this topic. So thank you so very much for that. If I could ask Dr. Ram to report in for your group. It's so funny to see people's face when I say their name on here when there's 100 people on too. But Dr. Ram, would you mind updating us on your group findings there?
Yeah, I was going to let Sister Mushe speak, if that's okay.
Yes, that's fine. As long as that's okay with her.
Yeah.
Yeah. Okay.
Okay. Good afternoon, everybody.
Hello.
Ram has said I should speak, so I will just be straight because most of what we discussed has been shared already here. I will start from the one that affects the health units, which has not been mentioned here, and that is affordability. And we are picking on this issue because we spend a lot of time educating women in the villages, wherever they are. We spend a lot of time educating their relatives. But most time, when they don't have the funds for to access qualified health services, no matter what you do, they still go back to the unqualified because of cost. So we ask ourselves in our groups, how can we help as MMM, as a group of this SafeBirth, so make our facilities, health facilities, affordable for women? With that, I think they can listen more when we encourage them to avail of quality health services in the hospitals. We also talk about working on the people's mindset, which has been mentioned. The cultural background is very strong. There are a lot of cultural background that take women away from the reality, the truth about preventing VVF and other maternal complications. And as the Sister Katie has well mentioned, we really need to get them to understand the reality. We need to work with all the people, the mother-in-laws, the mothers, and all others who are the ones stopping them from accessing the right healthcare services. So there we mentioned the working with focal groups in the communities and working with educated men and women in the communities who can speak, because we have been talking. But when they can hear from their own people, living with them, they may listen more. So we say we have to collaborate with these sets of people in the communities. So help them, when we educate them, when we partner with them, let them be the one to talk to their own relatives. And this we have started where we are here in the hospital, and it's working. Only that we need to do more in engaging these people. We can't just feel that we have the whole answer. They are the one living with these women. They know when there is a teenage pregnancy. They know when a woman is not attending an antenatal. So this sensitization should start with them. And so partnering with them will help us a lot in getting what you want. And the last one is what we said to be catch them young. Catch them young. Operation Catch Them Young. Going into schools, having a youth program that educates young people about who they are, not just women. What about young boys? What they see in social media, whatever the society is presenting to them, most of the time is wrong. So we need to direct this particular attitude by educating them, letting them know of what they should know, so that by the time they get to that particular age, and we mean starting even from primary school, not waiting for them to be teenagers, so that they will grow up with this mindset that they need to take care of themselves. So thank you very much. These are the major parts of what we discussed. There are more. We also talked about partnering with TBAs, which has been discussed as well. Thank you.
Thank you so much. Thank you so much to everyone who actively participated online. I think that's so fantastic that we had such lively conversations in person in the room, and then we had people all over the world connecting. I find this very moving. And I want to give a huge shout out to Mission Care staff for making this all possible, especially Megan, our champion for the rest of the We only had a couple of panicky WhatsApp messages from people at different parts of the world. So well done to everybody. Thank you so much. If you haven't done already, please make sure that if you're facilitating, you're putting your comments into the chat here. In the main chat, all of that is being stored and saved, and all of that will be compiled in a report. So if you didn't get a chance to report for your group, if you could please just type into the chat with a note taker or facilitator to make sure that your group's comments are in the compiled report that will be done after today. Would anyone up at the table like to say anything else? No? Good. Okay. Believe it or not, we have blazed through the morning. It is almost sandwich time. For those in the room, apologies to you for not here. We haven't figured out how to text a sandwich yet, but as soon as we do, you'll get one. 1 o'clock is upon us, but in our concluding remarks, we have invited Ken Gibson, who is the CEO of Marino and Leprosy. He's been working for over 20 years to end leprosy in the world and has done incredible global work. So he is here to share with us a few reflections on things to take away. One practical thing I will say is that we are starting to do quarterly education pieces, and Sister Dr. Carol Breslin is going to do something in September, which will be very useful, and you will all be receiving the report with the comments from the groups. And if you attended today, you will be receiving the follow-up materials from that. But at this time, I'd like to invite Ken Gibson to begin. Thank you. Thank you.
Well, thank you, Nadia. As I reflect on what I listened to today, here is the most outstanding sentence I heard in the room. Don't let me in, I'm smelly. And that's such a powerful, awful, but powerful sentence to have heard in the room. Because it sums up exactly what we're about here. We're trying to change that in some shape, manner, or means. In fact, we're trying to do even more than that. We're trying to make sure nobody ever utters those words again because they have no reason to. That sentence, and imagine uttering that sentence which says, I myself see that I'm an outsider. Imagine determining yourself that you're an outsider. Never mind how other people exclude you. It's one of those sentences that gets to the heart of what this program is about, because fistula affects people physically, mentally, socially, economically, and spiritually. It undermines everything we say as people of faith that gives us dignity, to be made in His image. So it's an evil in the world that attacks the very notion of being made and being worthy in God's image. And it doesn't just affect the ladies either, because it affects whole families, it affects husbands, it affects children, it affects communities. It's so much bigger than one person. That's the most powerful statement I have heard in the room today. But I heard it balanced by the word hope. Hope that we can end this, hope that we can restore dignity. And we've had little snapshots of things that are being done and things that are being achieved, restoring hope in people's lives. And yet there's that great bigger picture of ultimate hope, of removing this scourge from the world. I also heard mention of UNHCR and its 2030 target. As somebody who has spent nearly 3 decades working, advocating and designing programs to curtail disease and working with bodies like the UN and WHO, I know that that target is going to come and go without being met. Because the reality is that the numbers are bigger than any program has ever counted. We heard that from Shane today. It's like a tap that's overflowing. So we need to gear ourselves up to make sure that we are there when 2030 comes and goes and other people forget about it. Because I've seen that in other places. The deadline comes, it's not met, and everybody goes quiet. And you and I are going to be needed more at that point in time to make sure that this actually happens. It was the great 19th century missionary Hudson Taylor who said that God's work done in God's way never lacks God's supply. And so while we've heard that funding is an issue, we hold on to that promise that God's work done in God's way never lacks God's supply. And that drives us back to doing an audit ourselves of what we can bring to the table. That's one of the things that came out in the group that I was sitting in. What can we bring to the table? And I'm going to suggest to you something that I've suggested at that table. As people of faith, we don't believe that we're here randomly. We believe that we're each here with our own experiences and our skills and our understandings and our opportunities. And if we truly believe that God's work never lacks, getting tongue tied now. If we truly believe that, then we do an audit of what is needed and what can we bring to the table. And as a closing reflection, that's the question I want to ask. Do not walk away without asking that question. How do I fit in here? How do I commit to this? How do I see that this becomes a reality? Because if we are people of faith, and if we believe in hope, if we believe in healing, if we believe in restoration, then we each have to bring something to the table. And as somebody who has spent 20 or 30, more than 20, almost 30 years helping people find those places and those resources that they bring, I commit myself to helping you do that as well. You can track me down through the MMNs, through the SafeBirth4All, or what have you. I don't think you figure that out. When this program was launched 2 years ago, the great big ideal, the great big hope was held up of a day when no woman will ever have to suffer from fistula. Let's think beyond that. Let's think of a day when the word fistula is mentioned, people go, what's that? That's an ancient disease. That's an ancient illness. Isn't that an incredible vision? That's hope. That's healing. That's restoration. That's what we're called to.
Well done, Ken. There are absolutely beautiful comments online, aren't there? Thanking us all in the room, thanking Sister Sylvia for coming so far for us to be together today. Shane Duffy, thank you as well for coming so far. Jacqueline, all your hard work. Sister Ursula Sharp for giving us this calling. Edward Flynn for all you're doing. Tony Pike, sorry you're not in the room with us. And Ian from Mission Cara, Jennifer, all the Mission Cara staff. It takes lots of people in this global village to make this possible. But what I do want to say is I do feel a huge movement since last year and the year before that in this. And thank you to Janice, who runs our social media for SafeBirth4All and who is helping with our recreation, and Claire as well, who's helping with our redesign on our website. So we are in the midst of taking all your comments and everything you've been sharing. Thank you to Otterboard for the beautiful video at the beginning. We're going to be sharing all these resources with you, getting you these tools. And I know there are connections made in this room today that are going to go forward. You will be hearing from us about ways in which you can be involved in the 4 PART going forward. There are some amazing people in this room doing fundraising, including Andrea James Culler's doing incredible work in the US for sharing the word and raising money and all that. And there's so much going on. And our goal now is to take all that synergy and put it together in a great force for good, as Ken said. So thank you all so much for either being in the room or being online. And, you have our SafeBirth4All email address. You can let us know if you have additional thoughts after this or things you want to do. But I, for one, can say it's been a privilege to be here today. And thank you all so much for honoring us with your time. We deeply appreciate you. Bye now.